Now, at the outset, I would like to thank the organizers of this GSICON 2024 for giving me this opportunity to share a session. It's my privilege to welcome you all in the discussion of withdrawal of life support in terminally ill patient, which involves with ethical, medical, and emotional dimensions in healthcare. So now I request Dr. Haroon to present his topic.
A very good afternoon to one and all. It gives me immense pleasure and honor to stand before this august gathering filled with the best minds in medicine and talk about the topic of withdrawal of life support in terminally ill patients. Well, I will not make the introduction to the topic very elaborate because for my talk today, this PowerPoint is the life support. And I have been given strict instructions that if I take more time, this life support will be withdrawn soon. So before we move on, I thought of playing this clip from the movie Anand, which was released in the year 1971 as a introduction to my topic, just to set in the vibe and make sure that all of you get a good introduction about this topic.
मुशाए जिंदगी बड़ी होनी चाहिए, लंबी नहीं। हद करते हो। मौत के डर से अगर जिंदा रहना छोड़ दिया तो मौत किसे कहते हैं? क्यों दोस्त? मुशाए जब तक जिंदा हूं तब तक मरा नहीं, जब मर गया साला मैं ही नहीं, तो फिर डर किस बात का?
So these are my disclaimers. I have cut and edited some videos just so that I can make sure that the message reaches all the audience over here and no offense is meant to anybody. And my disclosures, I mean, you can just imagine a person speaking about withdrawal of life support and death. What kind of financial exposures will he have to make? So as we proceed today now, the process of withdrawal of life support in patients, terminally ill patients, is a very sensitive topic. It requires for us to deal with this topic with a lot of intense emotions. And as we proceed today, I am going to use anecdotes from certain cases and we'll discuss it in the form of cases and questions. The first case is of one Mr. Rao, who is a terminally ill patient with an advanced malignancy. He is currently in the ICU. His wife, Mrs. Meera, his sons, Vikram and Arjun, are actively involved in taking care of him. Dr. Sumana, who is taking care of him, gets to realize that the patient is now having a terminal illness and she wants to discuss the process of withdrawal of life support with the family. And she convenes a meeting, but only the wife and one son is present. They sign on the do not resuscitate orders for the patient, but one son is missing. The doctor is worried as to what legal implications it may have on her if this process is initiated. Our next case is a patient who has got a stage 4 pancreatic cancer. Her family members are coming and requesting you, please don't reveal the diagnosis to our patient because then she will get worried and tensed. So as a law-abiding doctor, what we are supposed to do in this scenario is the question for us. So should life-sustaining treatment be withdrawn from a patient who is brain dead? And can this be done when the person or their family or representative of the family has not consented to organ donation? Yes. In fact, there are certain states in our country, especially I think Kerala and Tamil Nadu, where if the patient is brain dead and the support is not withdrawn, the particular healthcare facility will be liable for action. Is physician-assisted dying legal in our country? No, physician-assisted dying is not yet legal in our country. Can patient refuse life-sustaining therapy? Yes, the patient has got all the right to refuse a life-sustaining therapy, even though the consequences of that may be life-threatening for the patient. He can refuse life-sustaining therapy, and disregarding our patient's will it may make the clinician to land up with lot of criminal or legal or other implications as per the law. Are withholding and withdrawal of life-sustaining therapy legally permissible in our country? Yes, they are. Can medical treatment be withheld or withdrawn from a person who is in persistent vegetative state? Yes, we can withdraw the support. Is withholding or withdrawing life-sustaining therapy the same as euthanasia? Is euthanasia legal in our country? No, euthanasia is not legal, and they are not that is withholding and withdrawing of the life-sustaining therapy is not same as euthanasia. Now, the legal battle and the legal struggle to come to the stage of this law has taken a long course in our country. But something really major happened in the year 2018 and 2023 based on the judgment titled Common Cause versus Union of India, which was initially pronounced in 2018 and revised by the Honorable Supreme Court in 2023. The most monumental thing happened this year when the Ministry of Health came up with guidelines, that is a draft guidelines, they have not yet become a law, regarding withdrawal of life support in terminally ill patient. Now, the Common Cause versus Union of India judgment, as well as the draft guidelines released by the government, they gave legal validity to advanced medical directives. They made the process of withdrawal of life support a standard of care in India. And until the parliament passes a law or the state legislature passes a law, the ruling of the Supreme Court in the 2023 and 2018 judgment is going to be the law in our country. So what does the law say about withdrawal of life support? This is what we are going to discuss in the coming slides. So what is meant by withdrawal or withdrawing of life-sustaining therapy? So withholding or withdrawing life-sustaining therapy means discontinuing some forms of therapy, especially ventilation, feeds, dialysis, antibiotics or other things, which are just contributing to prolonging the life of a terminally ill patient. Now, I want you to understand that whatever I am speaking here today is in the context of a terminally ill patient. These do not apply to patients who are suffering from a reversible condition. I'm sure all of you would have watched this movie. I want you to look at this movie very clearly. So, because the kind of terms we are going to discuss next are a little bit complex, and I will replay this clip again after some time so that the understanding of these definitions become easy. So what is actually meant by withholding or withdrawing life-sustaining therapy? So this is done when there is no reasonable medical probability of recovery from a terminal condition, or the patient is suffering from some end-stage condition, or there is a persistent vegetative state. And the treating team comes to a conclusion that any further medical intervention or course of treatment would only serve the purpose of artificially prolonging the process of dying. So what is the Advanced Medical Directive? Now, the Advanced Medical Directive is the cornerstone on which decisions relating to withholding or withdrawal of life-sustaining therapy are done. This is a document which is prepared by a person in a state of mind who is having the capacity to take his decisions, and where he mentions as to who are his surrogate decision makers when he loses decision making capacity, and what are his preferences, what are his choices, and how he needs to be treated when such a situation arises in his life. And what is a valid AMD? That's an Advanced Medical Directive. AMD is valid if it is executed by a person who is more than 18 years in age. It has to name 2 or more surrogate decision makers, and it has to be executed in the presence of 2 unrelated witnesses, and it has to be authorized by a notary or a gazetted officer. So what is the pathway in the decision making? The first step is to recognize whether the patient is having a disease condition which is irreversible and the patient is on life-sustaining therapy. If we ever encounter this kind of a patient, the next would be to check if the patient has got a advanced medical directive. If the patient has got advanced medical directive, we will start initiating a conversation with the patient's surrogate decision makers. However, if the patient does not have the patient doesn't have an advanced medical directive, the physician will again re-evaluate the patient completely. And then once he is convinced that this patient falls into the category that he is suffering from a terminal illness and has reached the stage where none of these life prolonging therapies are going to be helpful to him, then a decision to withdraw life sustaining therapy happens. But it doesn't end there. Once the treating physician is convinced about withdrawal of life sustaining therapy, the matter is put up to the primary medical board of the hospital, which consists of 3 physicians of more than 5 years experience. They individually assess the patient. If they are convinced that the life sustaining therapy should be withdrawn, then the matter is put up to a secondary medical board. The secondary medical board consists of 1 doctor who is nominated by the district chief medical officer and 2 other senior doctors with at least 5 years of experience. As if the secondary medical board also gets convinced regarding the withdrawal of life sustaining therapy, to proceed with the withdrawal of life sustaining therapy is done, and the judicial magistrate of first class should be informed. We need not wait for the approval by the judicial magistrate of the first class. So is withholding or withdrawing treatment akin to giving up on the patient? So by taking a decision to withdraw life sustaining therapy in terminally ill patients, we are not giving up on the patient. We are making sure that the patient's care is transitioned to palliative care, which focuses more on the quality of life rather than life prolonging interventions. So now let us go back to our video. I know there were too many terms: withdrawal of life support, primary medical board, secondary medical board, ABCD, etc. I want you to reimagine the characters in the video as I have labeled it there. These are the primary and secondary medical board. And now you watch this video again to understand.
जा सिमरन, जा जी ले अपनी जिंदगी, जा बेटा, जा।
So sometimes what we think could be the end of the story may be the beginning of some other story for the patient himself, because death in different cultures is perceived in a different way. For a soldier, death may mean something else. For a spiritual man, death may mean something else. For a person from a different culture, death may mean a different thing. So keeping the patient's choices in mind and taking decision becomes our primary responsibility. So is palliative sedation legal in our country? Yes. If palliative sedation is done with the idea of relieving the patient's suffering, then it is definitely legal in our country. And for those who are looking at appropriate definitions of these terms, I would refer you to this paper which was released by the Indian Council of Medical Research, where all these terms have been very specifically defined. Most of the decisions that we take in withdrawal of life support are based on the principles of autonomy, beneficence and non-maleficence and justice. Now I want you to watch the next video very carefully. So in this video you will realize that the person who is suffering from the disease knows very well that he is going to die because of the disease. The only thing he is asking for is companionship. He does not want to be put in a particular cell and he wants to live along with people.
चलो कैबिन में
नहीं नहीं नहीं, कैबिन में नहीं, वहाँ अकेले पड़े पड़े मैं मर जाऊंगा। चाहो तो अपने घर ले चलो, लेकिन वहाँ नहीं।
देखना कैसे बांध के रखती हूँ मैं।
बांध के मुझे कोई नहीं रख पाएगा मम्मी, ठीक निकल जाऊंगा।
So I think this video speaks volumes about the kind of thoughts, the kind of process the patient goes through during the phase of dying. So whether there is medical consensus or not, whether there are guidelines or not, to cure sometimes, to relieve often, and to comfort always should be our motto. And at any stage of life, from birth to death and to the process of dying, giving the patients a good quality of life should be our primary goal. Now, before I finish, I want to have certain words about death and the fear of dying. Although scientifically and medically, death may mean cessation of a biological function, absence of circulatory function, absence of neurological function. When we look at it from the patient's point of view, and the patient's family's point of view, there are many more things to it. There is a social perspective, there is a cultural perspective, and there is a religious perspective. And the problems faced by the patient's family are tremendous. They go through moral distress, they go through compassion fatigue, they go through burnout, and many of them even end up losing their jobs when they are caring for the patient who is in a terminally ill state. Now, this is one more video I am going to show you, which tells us that although life is very, very uncertain, the only certain thing in life is death. So I usually have conversations and discussions with my fellow doctors in OBG, pediatrics. So even though this is the only certain thing in life, our discussion and our preparation for this is not actually very well done. I'm really surprised when I think of a fact that the hospitals have a birthing suit, but they don't have a dying suit, where a person who knows that he is going to die can prepare for his death and attain very good palliative care at the end of his life. Now, when we look at the research and the data, we know that most of the patients have prioritized good death at the end of their life and not have opted for the kind of death which involves unwanted prolonging of life with life support systems. Now, if we have to educate our patients and ourselves to take these decisions, we have to be guided by ethical principles. We must make a clear-cut distinction as to whether our terminally ill patient is just alive on life support, where being alive on life support is akin to having just some biological life. Otherwise, there is no other sign of life in the patient. And being there to be living, it implies there are a lot of complex interactions one has with himself and the surrounding world and the environment in such a way that there is productivity for himself and the environment around him. Well, when time comes for my breath to become air, this is not where I want to be, and I think my lecture has helped you to understand and make choices where you also want to be. I will end my talk with this last video. Thank you, one and all.
Thank
And
you.
I think this clap should be for Sajesh sir and his team. They deserve a standing ovation for organizing such a beautiful conference and creating a benchmark as to how conferences are conducted.
Dr. Haroon, what can I say? Very poignant, very poignant. And it actually, thank you for taking us through so sensitively through many sensitive areas we as doctors have not been taught about adequately. During our curriculum days, there has not been enough chapters written on death, how we embrace death. We have been always taught how to save life, promote life, prolong life at any cost. But the cost, the worthiness of that cost has not been assessed. Again, the fact of the legal implications of medicine are not well taught at any stage, and we have to, in our later years, go to postgraduate courses in medical law and ethics to understand more of that. So thank you very much. There's a question coming up.
Yes.
If there's any time for the end, I'll have some more queries for
Dr.
you.
Haroon,
But madam,
congratulations, Dr. Haroon. You have spoken very well on the topic. But the second part of your question, you have not spoken so much, that the brain death. So what is brain death and how to diagnose? So this is the very critical stage, and the intensivities, or a physician. Physician is the person whose signatures allows the committee to, he gives signature, and then only the organs are taken out. So my question and answer is also there, because so many people, they don't know how to diagnose the brain death. And when we have diagnosed, 7 transplantation were done in our hospital in Dr. D.Y. Patil, lung transplantation, 2 kidney, liver, and cataract. So this part, even though this is a geriatric society of India, but we should know about the how to diagnose brain death, and the person who, social worker, and not the treating physician, the other person will convince the relative. That is the main issue in this brain death. When the social worker will conceive him, their relatives, and then they will be the hospital committee will give the permission. So this is the diagnosis and the decision, and you can save the life of the other person will live. So organ donation is a different part, but it is very important, and everyone should be able to know how to diagnose. There are some reflexes, doll's eye, and the test is there. So it should be done, I think so. So it's very good presentation. Thank you.
Thank you. Thank you,
Congratulations,
ma'am.
sir.
yes, sir.
Hello, Dr. Haroon. I am Dr. Bijo.
Yes,
I'm
sir.
a full-time palliative physician for the past 21 years. And boy, I did not expect to see this kind of a presentation in GSI conference. This has been really top class. I must congratulate
Thank you, sir.
And I think this can be used as a awareness tool for doctors not in palliative care as well as in general public. And just a word that in palliative care, we are, especially when providing end of life care, which we do on a daily basis, the focus is not death. The focus is on comfortable life, peaceful and dignified life till the point of death. And the research shows that not only the quality of life improves, but the quantity of life also improves. So thank you so much for
Thank
that.
you, sir. Thank you.
Yeah, thank you, Dr. Haroon. We wait for more questions, some more time left. The point is, you have touched upon neglected areas of our education in medicine. Palliative care was another one. Again, analgesia during terminal care, that's underutilized because there's always a reluctance to give morphine to patients who are terminal. Because pain is something we can avoid, distress is something we can avoid, both for the patient and the thing. So you're highlighting that point, analgesia, and then the unnecessary use of ventilatory support when the cause is futile, perhaps for some commercial gain, is perhaps unwarranted, and as you said, illegal if life is being prolonged. So the question is, do you recommend that all of us who are privy to your talk should have advanced directives written out when we are cognizant we have got, compos mentis, or should we have to go through that process of having a magistrate and you had 2 witnesses and 1 gazetted officer countersigning my advance declaration? And how should there be a format for that? That's practical advice. If all of us listen to your talk and are willing to go forward, how do I write my advance directive this evening? So if something happens to me tomorrow, I'm safe.
So, sir, the whole idea of having an advanced medical directive is that we are able to decide on how we should be treated when we lose decision-making capacity.
Yeah.
So anybody above the age of 18 can make an advanced medical directive, And the whole idea in which the Supreme Court pronounced the repeat judgment in 2023 was the 2018 judgment had made the making of the Advanced Medical Directive a little bit complex. So I think we should thank our professional bodies, especially Indian Academy of Palliative Care and ISCCM, who re-appealed to the court, and the court changed the decision. So actually making the Advanced Medical Directive is very simple nowadays. The proforma is available freely on the ICMR, IAPC, ISCCM guidelines network. Also, there is a body called as ELICIT, which is fighting for the cause of good death. And in their website also, this proforma is available. All we have to do is we have to get it filled. We have to put the wishes. And earlier, this Advanced Medical Directive had to be made in the presence of a judicial magistrate of first class. So the simplification here is that now it can be made in the presence of a gazetted officer and 2 witnesses. But the more important thing is we should convey that we have an advanced medical directive to the hospital where we are treated and to the people whom we are appointing them as our surrogate decision makers. So the earlier we make our advanced medical directive based on our preferences, the better. And if we have an advanced medical directive, it doesn't mean that like say I make an advanced medical directive at the age of 30, but at the age of 40 or 45, my preferences change, my spiritual values change. I can always change my advanced medical directive. Only thing is the authorities must be notified about it. My treating team should be notified about it. My next of kin, my family member should be notified about it. The website of All India Institute of Medical Sciences has got very good guidelines on this. So we can just go to their site also and download it. It's free of cost, the proforma for making the advanced medical directive.
And the last question I'll put. Yes, sir. Please do.
Almost several years. But I can tell you the way I looked at it, because initially I was the physician and head of that medical unit and a professor. So every morning when I used to enter, I used to listen to the cries during nursing, during feeding, some pain. And then the matter continued. Then one day I became the dean of the same institute. And I was concerned about the courts and legal procedures. Ultimately, in 2012, after my innings got over, she succumbed. Yeah. The story was both ways. As a living person, agonizing to the treating team, because nurses had their own way of devotion. And secondly, thereafter many press calls and somebody writing books and all that. It was just a different sort of thing. But what you pointed out is so very important. And therefore, that made me write a big book, editorial on end of life issues. That is in Postgrad Journal of Medicine. It's quoted and referred quite often.
Yeah. So the last comment I'll make is about the death suite that you talked about, living suite. There is no spiritual support for the dying person in the religion I come from, Hinduism, whereas I've seen that easily accessed as chaplaincy services for my Christian patients. Anything that should happen for that, because spiritualism towards the end of life to ease the agony, the panic, the anxiety of death is very important.
Yes, sir.
So in that model that you have, there should be a spiritual specialist.
Yes, sir.
But none of the organizations, Ramakrishna Mission and the other cultured educational institutes were able to offer that to my father. So that was actually a burning hole in the end of life care package, spiritual support at the time of death or the weeks around it. Thank you very much for those poignant blockbusters. And they know death better than us, the directors and the writers and the script writers and the actors, because they are simply teaching us in their words what you have coined for us in our very important, poignant and practical and very heart-wrenching
I think that movie
episodes.
Anand was roughly released 50 years back.
Absolutely.
And they were sensitive to the aspect
they
that
were sensitive.
The process of dying should be a comfortable process.
And here we are still
Yes,
discussing it.
Yes, sir.
Thank you, sir.
Thank you, sir.
Very
Thank
kind, very poignant. Thank you.